A group at Emory some years ago published an article where they sketched different anatomic variations of post-valvular pulmonary stenosis. We can see that the pulmonary trunk can be involved focally or diffusely narrowed. The proximal right and left pulmonary arteries can have short or long narrowed segments, and there is a malignant form which is intrapulmonary multiple peripheral pulmonary stenosis. The latter is not possible to be treated surgically. The proximal stenosis occasionally are amenable to interventional techniques such as balloon angioplasty or stenting. This is an angiogram in the frontal and lateral view of multiple peripheral pulmonary stenosis. Note the tubular narrowing of a left lower pulmonary artery. And often these narrowed portions are accompanied by post-stenotic dilatation. Pulmonary hyperlucency can be caused by a technical factor such as off-centering of the X-ray beam, can be related to asymmetry of the soft tissues of the chest wall, like in patients who have agenesis of the pectoralis major. And the intrapulmonary causes of hyperlucency are parenchymal disease or primary vascular insufficiency. Particularly in children, lucencies, such as seen in this case, affecting the lower half of the right lung, one has to suspect the possibility of pulmonary stenosis, branch stenosis. In an adult, one would have to consider a massive pulmonary embolism. The venous face of an angiogram in the previous case shows that the right hemithorax, the lower half, is oligemic, and there is a flow retardation in the pulmonary veins. We can see opacification of the right upper lobe and left pulmonary veins, and we see a very faint visualization of veins of the right lower lobe. This patient had pulmonary stenosis affecting the right lower pulmonary artery. These patients often have chest murmurs that are heard within the lung itself, not centrally, but peripherally detectable. In this patient, the left lung was oligemic. Are we dealing with a ball valve mechanism that is some sort of obstructing lesion of the proximal airway, like a foreign body or a tumor, or are we dealing with a primary vascular insufficiency? The patient gave no history of pneumonia, and there were no respiratory problems. In such a situation, comparison of inspiratory and expiratory films or fluoroscopy will show that the two domes of the diaphragm move synchronously if the cause of the hyperlucency is a primary vascular insufficiency. If we were having air trapping as a cause of the hyperlucency at the site of the obstructed bronchus, one would see that the diaphragm does not rise in expiration, and one would detect a shift of the mediastinum, comparing inspiratory and expiratory maneuver. Selective pulmonary angiogram shows flow retardation through the left pulmonary arteries. Note how the right pulmonary arteries fill readily, and we faintly see the proximal left pulmonary arteries. In the venous face of the pulmonary angiogram, we see opacification of the right pulmonary veins and absence of filling of left pulmonary veins. Actually, they fill very faintly, and there is no adequate perfusion of the left lung. In a later angiogram where we already see the aorta, now we see the left pulmonary veins. So asymmetric pulmonary blood flow suggests an obstructing lesion in the proximal pulmonary. A pulmonary angiogram of the same patient in the lateral projection shows a focal narrowing at the takeoff of the left pulmonary artery with a slight poststenotic dilatation. So branch stenosis of the pulmonary trunk caused the hyperlucency of the entire left lung.